Childbirth is one of those things in life that people plan down to the very last detail. But here's the thing. In obstetrics, that beautiful, detailed plan can flip into a life or death situation in a heartbeat. Today, we're going to pull back the curtain and go inside the clinical playbook that medical pros use to handle these exact high-stakes moments. So, really, what does happen when that plan just goes right out the window? How do medical teams make the right call when every single second counts for both mom and baby? We're going to cover all of it, from scheduled surgeries to those sudden, terrifying crises, and the critical recovery that has to happen afterward. All right, let's kick things off with one of the most common surgical procedures in the entire world, the cesarean section, or as we all know it, this C-section. This is a procedure that every single healthcare professional in this field has to be ready for, whether it's been scheduled for weeks or decided on in literally a matter of minutes. So at its most basic, a C-section is just a surgical birth, right? An incision is made through the abdomen, then the uterus, and the baby is delivered. It sounds pretty straightforward, but the reasons for it, and maybe more importantly, how it's done, have massive implications for a mother's health and any pregnancies she might have down the road. Okay, so let's get into why a C-section might even be on the table. A really great way to remember the main indications is this little mnemonic, MAP-FAM. This covers the big ones, from the baby being in the wrong position, that's malpresentation, like a breech baby, to serious issues with the placenta, like an abruption or a previa. It also covers things like fetal distress, an active herpes outbreak, or sometimes it's simply the mother's request. Now, here's something really important to understand. Not all C-sections are created equal. The type of incision made on the uterus is a super critical detail. The most common one is the low transverse. You might have heard it called the bikini cut. It's less painful, and this is the key part, it makes a vaginal birth after cesarean or a VBAC a possibility in the future. The classical vertical incision, well, that's a whole different story. And that brings us to a hard and fast rule in obstetrics, an absolute, non-negotiable medical fact. If a patient has a classical vertical scar on their uterus, the risk of that uterus rupturing during a future labor is just way too high. That means they are never a candidate for a VBAC. Period. It's a permanent no-go, and trust me, it's a favorite question on nursing exams for a reason. Getting a patient ready for a C-section follows a very clear, logical sequence, all designed for maximum safety. First step, the patient is made NPO, that's nothing by mouth, to cut down on the risk of aspiration. Then we get IV fluids and antibiotics going. After the surgical site is prepped, we hit the final, crucial step, making sure that a fully informed consent form is understood and signed. Okay. Let's shift gears now, and it's a big shift. We're moving away from a planned or even an urgent surgery to a true all-hands-on-deck obstetrical emergency. This is a situation where your actions in the first 60 seconds can literally determine the outcome for everyone. A prolapsed umbilical cord, this is probably one of the most terrifying events you can have in a delivery room. What's happening is the baby's lifeline, the umbilical cord, has slipped down ahead of the baby. So with every single contraction, the baby's own head or body is compressing that cord, completely cutting off its own oxygen and blood. It is an absolute race against the clock. And you know, the first sign of this absolute disaster usually isn't some flashing light on a monitor. It's the mother saying these exact words. I feel something between my legs. That statement has to be like a fire alarm in your head. It requires an immediate, sterile vaginal exam to check if you can feel a pulsating cord. When this happens, there is a very specific, very rigid sequence of events. First, you scream for help, and this is critical, you do not leave the patient's side. Your number one non-negotiable first action is to manually get the pressure off that cord. You insert 2 gloved fingers, find the baby's head, and you physically lift it up and away from the cord. And your hand stays there. It stays in that exact position all the way to the operating room until that baby is safely delivered by C-section. Okay, here it is. This is the biggest mistake people make, and it's a classic test question trap. Your gut instinct, your first thought, might be to grab a Doppler and check the baby's heart rate. That is the wrong first move. In this emergency, intervention comes before assessment. You don't have time to check, you have to act. Your only priority is to get your hand in there and lift. All right, deep breath. After the sheer intensity of birth, whether it was a C-section or vaginal delivery, the focus has to shift to recovery. This whole period, what we often call the fourth trimester, demands a really careful head-to-toe assessment to catch any complications before they become dangerous. It's all about making sure mom is healing the way she should be. So to keep this pretty complex assessment organized and make sure we don't miss anything, we use the gold standard mnemonic Bubble E. It's great because it walks you right through every critical system: breasts, uterus, bladder, bowels, lochia, episiotomy, and extremities. It's just a systematic checklist to make sure nothing gets overlooked. You know, out of all the checks in Bubble E, one of the absolute most important is assessing the uterus. This one simple question, is the uterus healing the way it's supposed to, is directly connected to the single biggest risk in the postpartum period: hemorrhage. So what are we actually looking for? Well, a healthy, healing uterus should feel firm, kind of like a grapefruit. It should be right in the midline of the abdomen, and it should be at or just below the belly button. The danger signs: a boggy or soft uterus, which means it isn't contracting down like it should be, or one that's pushed off to the side, which is a classic sign that a full bladder is getting in the way. Next on the list is checking the lochia. That's the postpartum bleeding. It actually tells a really clear story about the healing process because it follows a very predictable pattern. It starts as rubra, which is bright red, for the first few days. Then it transitions to serosa, which is more of a pinkish brown, for about a week. And finally, it ends as alba, a whitish yellow discharge. Any major changes to that pattern could be a sign of trouble. And this, right here, is the single most critical red flag when we're talking about bleeding. If a new mom is soaking through a full perineal pad in 15 minutes or less, that's not just heavy bleeding. That is defined as an active hemorrhage. It's a medical emergency, and it means we have to intervene right now to stop the bleeding and get her stable. Wow, we've covered a ton of ground, right? From planned surgeries to terrifying emergencies and the whole recovery process. So let's just boil it all down into the absolute must-know, rapid-fire takeaways that you need to remember. These are the absolute pearls. Prolapse cord, you lift first, period. A boggy uterus, you massage it and you massage it firmly. Uterus pushed over to the right, it's a full bladder, go get him to pee. A classical incision scar, absolutely no VBAC ever. A pad soaked in 15 minutes, that's a hemorrhage. And that awful, intense gas pain after a C-section, the best medicine is to get up and walk. These are the little things that literally save lives. So we've just walked through the entire clinical playbook, right? We know how to manage birth and ensure physical safety during that crucial recovery time. But that brings us to one last really important question. With all this focus on fundal checks and incision care, what's the one part of a new mother's journey, whether it's mental, emotional, or social, that we as a healthcare community tend to overlook the most? That's definitely something we're thinking about.